as a pediatric surgeon, I enjoyed a lot your session. Congratulations, it was really nice. My name is Siham LAZREG. I'm from Algeria, and I'm here on behalf of the French Society of Ophthalmology. I'm a member of the board, and it's one of the oldest societies in the world. It's 140 years old. My talk today is on the pediatric dry eye, and I will start my talk by one of my cases, one of my patients. She's a 6 years old girl, and she was referred to me just for a certificate. It was a hopeless case. She saw many colleagues, and she was treated for allergy, for herpes disease, and this was her cornea's bilateral neovascles in the cornea the first day. And she was referred as the last hope, and also for a certificate to go in a special school because she was in the age of school. Then, pediatric dry eye is maybe frequent, but it's not very known. It's underdiagnosed and underestimated because children are not complaining. The tendency of children to report fewer symptoms compared to adults for similar degree of ocular damage may also lead to this under-reporting of this ocular surface problem. And this, in this case, in pediatric dry eye, we can have many comorbidities, and it can lead to many causes. And it can occur with the number of congenital, autoimmune, endocrine, or inflammatory disorders. And in this presentation, we'll discuss some epidemiology and and all of these etiologies. Concerning the epidemiology, all of us, we know that dry eye is a very frequent disease, and in adults, it's reported to be the prevalence from 5 to 50%. And there is really a paucity in publications in the pediatric cases. Some studies, and 4 of them, reported dry eye in children to be 10 to 44%. And there is a little or no information in all the publication regarding the impact of the signs and symptoms in the children population. The signs and symptoms are same in adults, but the children are less complaining. They have the redness, the itching, the hypersensitivity to light, exactly the same symptoms, but the complaining is really less. And to do the clinical examination, when you can put the child into the slit lamp, it's easy, but if not, it's less more complicated. And we can as well perform all the chamber test, breakup time, and all the automatized machines and examinations. What are the causes in this population? MGD is the first cause, environmental, allergy, congenital, or GVHD. The GVHD, or ocular rosacea, is defined as a posterior blepharitis, as it's very, very common, at least in my country and in the Mediterranean area. It's a very common disease in children. We have many rosacea and many MGD in pediatric population, and the main manifestation in children, it will be chalazion. Then, when we have a recurrent chalazion, we need to see what's happening into the meibomian glands, and in most of cases, if we are not treating at this stage, we can see all the complications after. Then the recurrent chalazion is the most frequent symptoms. Then we have the corneal involvement, and we can have many of them. We can have follicular keratoconjunctivitis, keratitis, infiltrate, neovascles, and even perforations or corneal ulcers. And as you see, all these pictures are belonging to pediatric people. Then back to my patient. Then it was her picture at day 0. And as I told you, it was a hopeless case, bilateral blindness, and I started to examine her, and just I asked her father one question: did she expected any chalazion? And he told me yes. Many years ago, when she was 2 years ago, she had a recurrent chalazion. It was only the key point. And then I told him, let us just try a treatment, and if it doesn't work, after 3 or 4 months, I can give you the certificate to go to the blind school. And then, fortunately, as you see, after only 2 weeks of treatment, she was like this. After 1 month, she was like this. After 2 months, this is her picture. And the surprise is now, this is her picture. Then, thank you. And really, it was one of my very altruistic cases, not only clinically, because she was blind and the parents were really hopeless. And only if you do only a questionnaire, if you just ask one question, we save all her life, because she was supposed to be blind and she was treated for herpes zoster, for a severe allergy. She had many treatments, and she saw many doctors, and they didn't ask only one question. And don't expect to see the rosacea before the clinical, before the eyes. She developed, this is the girl, she developed the rosacea 3 years later. Then don't wait for the skin manifestation before the ocular manifestation. And in children especially, they can develop the problem, the ophthalmology problem, before the skin problems. The second etiology of dry eye in the pediatric population can be environmental and lifestyle. And as you know, all our childs now are on the screens, and this is one of the most reasons of dry eye in children that I am seeing in my office. And they are all exposed to environmental and ocular challenges. Then we have an increase of reports of dry eye in pediatric population due to the use of the screens. And they are all on their smartphones or on their tablets. And I found many papers on that. And we have also inadequate blinking. They don't know how to blink. They have, when they have problem in their refraction, it can lead to dry eye. All the myopia treatment that we are giving to our patient are preserved, and then they are developing as well dry eye. And in my country and in Africa, maybe in India also, we have a vitamin A deficiency, and it can lead to dry eye also in this pediatric population. The ocular allergy and the dry eye are for sure very, there is a big relationship. I'm seeing thousands, I can say thousands of VKC, because in Algeria it's a warm climate, and I think that in India it's the same. And they all developing because of the chronic inflammation, because of the chronic ocular surface disease. They are developing meibomian gland dysfunction, dry eye, and this relationship is now not to demonstrate, it's a fact. Then we need to treat both the ocular allergy and the ocular dry eye and the dry eye. GVHD, the bone marrow graft is a saving procedure. There is no doubt. And now our colleagues hematologists are doing more and more, because they are extending the indications. Then for the beta thalassemia, for many diseases, they are doing bone marrow graft. And I'm seeing in my clinic many pediatric GVHD. They are really very, very miserable, because the disease is very severe, and they are developing the ophthalmic symptoms are really very, very important. Then in these patients, we need to take care of them. Once they do the bone marrow, we take care of their eyes, because they are developing severe dry eye and severe corneal involvement. We have also many congenital dry eye disease, congenital alachremia, aniridia, congenital anesthesia. And as you see, this is a 3 years old boy with a congenital plasminogen deficiency, which is very common as well in Algeria. I don't know here, but it's common, and it's one of the causes of dry eye in children. Then how can we manage this dry eye in children? The same as in adults, but we need to explain the MGD treatment and the lead hygiene, because in pediatric population it's not so easy. Then we need to explain to the parents how to do the eyelid hygiene, the massage and the warming. We can perform IPL, I'm performing whatever the age, and we can also perform a manual or automatic hygiene with the blepharo exfoliation. It's very effective in the treatment of chalazion in the pediatric population. For the antibiotics, this is what I gave to my patient. I gave a treatment of azithromycin. It was a local azithromycin twice a day for 5 days, and I repeat the treatment 3 months. And for the first course, I'm giving steroids for the same 6 times per day for the same period. Then I repeat the treatment 3 months, and you saw the results. The anti-inflammatory drugs, we give steroids and also cyclosporin, tacrolimus in the severe cases. The prevention of dry eye is the entourage, is to explain to them to avoid the screens, to help them to teach them how to blink, and to wear the correction. Just to conclude one word, the dry eye in children is not that rare. This is now it's a common condition, and we need to give them more attention than adults, because they are not complaining, and when we are seeing them at in the stage of complication. Just please join us this year. We have a new society. It will be our 3rd Congress, the Dry Eye and Ocular Surface Society, and our next meeting will be in Bangalore, here in India. Please join us, and you are very welcome. Thank you.